Hello, I'm Dr. Hannia Verdzzo Ruiz, and I'm gonna talk to you about sleep disturbance in post-traumatic stress disorder. I chose this topic because through this rotation, we have seen some patients with different kinds of trauma, and also Dr. Bernard and Dr. Stein have taught us about the importance and the impact of sleep in health. As an overview of the content, we're gonna have an introduction. We're gonna talk about post-traumatic stress disorder, the sleep disturbances in this condition, its prevalence, the correlation, the assessment, and the treatment. As a little introduction, post-traumatic stress disorder, or PTSD, which I'm gonna refer us from now on to save a little time, has an extremely high comorbidity with sleep disorders, showing values from 70 to 91%. As we know, sleep is a vital physiological process, and the disruption in this process affect the performance in multiple domains of functioning, this including cognitive, emotional, metabolic, and immunologic. Furthermore, sleep disorders contribute to major depression, substance abuse, impaired daytime function, negative long-term health consequences, and it increases the risk for suicide. Okay, so PTSD is characterized by intrusive thoughts, nightmares, flashbacks, avoidance of reminders of the trauma, hypervigilance, and sleep disturbance, which is the one that we're gonna focus on this lecture. And all of these symptoms lead to considerable social, occupational, and interpersonal dysfunction. Continuing with the prevalence, among civilians, there's a 1-year prevalence from 2.3 to 9.1%. and a lifetime prevalence from 3.4 to 26.9%. Okay, so PTSD and sleep have a complex relationship. Thought sleep problems accompany many mental health problems. Sleep problems in PTSD are actually considered part of the disorder. And among the symptoms used to diagnose PTSD, 2 are directly related to sleep. These are hyperarousal and intrusion. These can manifest as insomnia and nightmares, and they both contribute to the development and the maintenance of PTSD, and they may even be present without the PTSD diagnosis. These sleep problems interfere with the brain's ability to process memories and emotions, and they slow down the recovery process after the traumatic event. Okay, so as I mentioned before, sleep disturbances frequently occur in PTSD. They are reported by 70 to 90% of the patients. The most common ones include insomnia, nightmares, and obstructive sleep apnea. Beginning with the nightmares, about 50 to 70% of the patients with PTSD suffer from recurrent distressing nightmares. This can be an exact replication or a more symbolic representation of the traumatic event, and they primarily occur during REM sleep. Talking about insomnia, up to 90% of individuals with PTSD report difficulty sleeping, whereas the application of the DSM-5 criteria for insomnia suggests a range of 35 to 61%. Insomnia is often also related to an increased autonomic arousal and a fear of sleep, for example, fear of losing control and fear of having nightmares. PTSD is also associated with obstructive sleep apnea. Concerning between 40 to 90% of PTSD patients. And there's a proposal of a bidirectional theory, which suggests that trauma-related sleep fragmentations increase the vulnerability of the upper airway collapsibility, and vice versa. The sleep fragmentation from the sleep breathing problems worsen the PTSD symptoms. Also relatively prevalent in PTSD, but with unclear frequencies, there can also be present a periodic limb movement disorder. This is thought to be associated with arousals and awakening, sleep paralysis that is often accompanied by distressing experiences, and panicked awakenings from the sleep with poor or no recall from the dream. Talking about the correlation between PTSD and sleep disturbances, as I mentioned before, research strongly indicates that disturbed sleep constitutes a predisposing, precipitating, and perpetuating factor for PTSD. And furthermore, sleep disturbances affect the clinical course of PTSD. Poor sleep quality is associated with reduced responsiveness to trauma-focused therapy, and interventions targeting insomnia, nightmares, and obstructed sleep apnea improve sleep quality and ameliorate the daytime PTSD symptoms. Looking at the neurobiology, this image shows the main brain regions broadly implicated in anxiety-related disorders. The amygdala and the insula are key structures involved in the processing of aversive stimuli and the expression of fear and anxiety. Most consistently display hyperactivation in task-based neuroimaging studies of anxiety-related disorders. And in contrast, the middle prefrontal cortex tends to display a hypoactivation in anxiety-related disorders, especially in PTSD and depression. And the treatment of these disorders has been associated with an increase in the middle prefrontal cortex activation that relate to the symptoms improvement. In addition, the dorsal anterior cingulate cortex, with some exceptions, shows increasing activation in anxiety-related disorders, which is thought to reflect the role of this structure in processing and expression of fear and anxiety. Okay, so function connectivity studies in anxiety disorders generally indicate decreased connectivity between regions that modulate the negative emotions and the emotion processing regions. In the physiological findings, we have seen that studies have shown that PTSD is associated with more stage N1%, lower slow wave sleep percent, and a greater REM density, as well as REM fragmentations. This as compared with mixed control groups. And these characteristics may result from increased noradrenergic tone during REM sleep in PTSD patients. In a little summary, published sleep physiological studies overall indicate a hyperarousal during sleep in these disorders, with effects on sleep architecture and continuity that may impact some important functions of sleep. As a causality, the reciprocal relations between sleep disturbance and PTSD suggests that disturbed sleep continues a causal factor in PTSD. This causality is partly based on sleep's role in memory consolidation and emotion regulation. While memory consolidation takes place during both slow wave sleep and REM, the processing of emotional memories is thought to be happening primarily during REM sleep. So in PTSD, traumatic memories arise in part from a failure in the extinction learning. For example, learning that the previous conditioned stimulus no longer represents a threat. For an accurate diagnosis of PTSD according to the DSM-5 criteria, the clinician administers a PTSD scale known as CAPS-5, and this is a structured interview to diagnose current and lifetime PTSD. However, the CAPS-5 it's not sufficient for assessing the prevalence of sleep disorders as it contains only 2 questions related to the sleep problem. So diagnosis of sleep disorders are easily missed and misdiagnosed. So we need specific criteria. Therefore, an accurate assessment is essential for the diagnosis of these sleep problems. We have to include sleep history, present sleep quality, sleep-wake behavior, screening for sleep disorders, assessment of daily routines, diet, substance use and abuse, medication, mental state, and the presence of a disease or the presence of pain. For the treatment, the high incidence of sleep disturbances associated with trauma-exposed and PTSD points the need for an effective sleep intervention for the trauma survivors. We have non-pharmacological treatment and pharmacological treatment. With or without PTSD, non-pharmacological treatment interventions are a first choice in the treatment of insomnia, nightmares, and other parasomnias. Beginning with insomnia, for insomnia, the cognitive behavioral therapy has shown the most evidence efficacy. This consists of several therapeutic components targeting different aspects of the sleep disorder. We have psychoeducation about sleep and sleep hygiene, relaxation training because of the hyperarousal, behavioral interventions such as stimulus control, focusing on reconnecting the bed with sleeping, and cognitive therapy. For nightmares, the most evidence is found in imagery rehearsal therapy. This is a technique for describing the nightmare story towards a better ending. The new dream is subsequently a rehearsal through the imagination. And for the obstructive sleep apnea, continuous positive airway pressure or CPAP has shown to successfully reduce PTSD symptoms, including the nightmare frequency, and possibly by stabilizing the arousal system. Continuing with the pharmacological treatment of sleep disorders, several types of drugs have been specifically evaluated in PTSD-related sleep disorders. And despite cognitive behavioral therapy demonstrating superior long-term outcomes over medication, still the sedative hypnotic prescriptions and use of off-label medications for sleep continue to be primarily treatment recommendations in PTSD diagnosed groups. For the GABA receptor agonist, these medications potentiate the effect of GABA, resulting in inhibitory activity in the central nervous system. So benzodiazepines are commonly used, but their use is controversial in the treatment of insomnia. Their use is not recommended due to the emergence of tolerance, their association with depression, aggression, and a worse psychotherapy outcomes. So they only provide a short-term benefit. And the non-benzodiazepine hypnotics carry fewer risk, but they need to have further evaluations in PTSD patients. We also have trazodone and nefazodone. This cause sedation and promote sleep. In small unblinded studies, these drugs has shown to promote sleep and reduce the nightmares in PTSD and in depressed patients. Trazodone may be particularly helpful for patients with alcohol use disorders and obstructive sleep apnea, where the GABA receptors agonists are contraindicated. Talking about the antipsychotic drugs, many atypical antipsychotic drugs are sedating and show evidence in the efficacy in PTSD-related insomnia and nightmares, but some close monitoring of negative effects such as hangover, metabolic dysregulation, and induction elevation of the restless leg syndrome. So they need more monitoring to these drugs. Finally, the adrenergic drugs, such as prazosin, are best supported by evidence, and they show an improvement in nightmares as well as in insomnia. So considering current evidence of pharmacological treatment of insomnia and nightmares in PTSD should be regarded as a temporary and additional rather than an alternative to psychological interventions. Well, as a conclusion of the topic, research has conclusively shown that PTSD is often associated with a variety of sleep disorders that affect the development, maintenance, and the recovery of PTSD. Therefore, early and comprehensive detection of co-occurring sleep disorders and a timely treatment are of highly clinical significance for trauma and PTSD patients. And that's it. Thank you for your attention. I don't know if anyone has any questions.